Today we'll be talking about the shoulder. As always, if you ever have any questions, please feel free to email me at my email address listed here. Here are the learning objectives for this lecture. We're going to start off and talk about the bony parts of the shoulder, or the osteology of the shoulder. There are three major bones that comprise the shoulder: the clavicle, the scapula, and the humerus. For the purpose of this lecture, we're just going to be talking about the proximal humerus, as the rest of the points of the humerus we'll talk about when we talk about the arm. When looking at an anterior view of the humerus, we have a few important bumps and grooves that we need to name. The first and largest is going to be the greater tuberosity. Anytime you'll hear tuberosity, you will want to always think bump. These are usually good attachment points on the bones. And the greater tuberosity is the largest one of the proximal humerus. This is going to be slightly posterior to a midline coronal section through the shoulder, and you can actually feel it if you put your fingers just behind the midline of that shoulder and kind of palpate pretty deeply, and you can feel that bump. Anterior to the greater tuberosity is the lesser tuberosity. It is much smaller in size, hence the name, but it is no less important. In both of these, the greater and lesser tuberosity are separated by the intertubercular groove. The last tuberosity on the anterior side is the deltoid tuberosity. It's going to be about third way down the shaft, kind of anterior midline. It's almost on the lateral view of the humerus, but it should be a pretty distinct bump about a third way down the shaft of the humerus. And we'll talk about this later, but the name kind of gives it away, as it's the attachment point for the deltoid muscle. Next, moving on to the scapula, looking at the superior edge of it, we have two projections. We have an acromion and the coracoid process. So these are going to be elevations, projections of the scapula bone. Coracoid is going to be very anterior, while the acromion is actually coming from a posterior view and will kind of reach into and become visible in the anterior view. So coracoid is anterior all the way, acromion is more posterior to that. Looking at the scapula body, starting at the superior edge, we have the superior angle, which is just the kind of point that the scapula comes to on the superior side. And if you look straight down inferiorly to that, you have the inferior angle. Now, between the superior angle and the inferior angle towards midline, so this is going to be the spot that's laying right next to your vertebrae, is going to be the medial border. This is quite thin and really can be used most effectively as an attachment place for muscles, but also help us kind of determine some borders that we'll talk about in a little bit. Then we have our lateral border that's kind of sandwiched between the scapula and the humerus, and this is much thicker than the medial border. And that's because most of your weight-bearing exercises for your shoulder will lay on that lateral border, and so it needs to be thicker to be able to support all of our weight. If you look just superiorly to the lateral border, there'll be a brown and gray colored spot. These are going to be your infraglenoid tubercle and your supraglenoid tubercle. The names come about because where the head of the humerus sits in, so creates that ball and socket, the socket portion of the scapula is actually called the glenoid fossa. So supraglenoid means it's above the glenoid fossa, and infraglenoid means it's below. Tubercle, tuberosity, means bump, so it's a bump above and below that glenoid fossa. And then in the center, there's a big kind of depression. It looks like someone kind of took clay and kind of like patted their hand down on it, and that is called the subscapular fossa, excuse me. Moving on to the posterior side, We still have our greater tuberosity on the humerus that we can see. Deltoid tuberosity is going to be very difficult to see. The lesser tuberosity and the intratrabecular groove are going to be impossible to see. But you still have that head of the humerus sitting within that glenoid fossa, or the cup, the ball and socket of the shoulder. You can still see the superior angle, inferior angle, medial border, and lateral border. Also see that infraglenoid tubercle, while the superior glenoid, supraglenoid tubercle is actually hidden by the acromion. Now, the new structures that we need to see, we have two fossas and a bony protrusion. So we have a supraspinous fossa, which is going to be an indention on the superior posterior view of the shoulder. You have an infraspinous fossa that's going to be inferior to that. And separating them and also giving its name is going to be the scapular spine. So infraspinous, spinous with the scapular spine, so it's below the spine of the scapula. And then the scapular spine will actually extend and create that acromion. That's why it starts in the posterior view and you can see it in the anterior view. So one kind of a big thing to take away from this is need to know all of the names, but if they're a little bit more difficult for you to memorize, you can always use the names as your guiding point. So they typically tell you where they are: a superior, inferior, medial, lateral, and then the base, the kind of big part of the word, can tell you what it's around. So like supraglenoid is superior to the glenoid fossa. Infraspinous is inferior to the spine of the scapula. Things like that. Those are things that you can keep in mind throughout this entire course. Most of these osteology names that we just went over can actually be palpated in the shoulder because it's a pretty superficial structure. So clavicle, the acromion, coracoid, greater and lesser tuberosity, spine of the scapula, the borders of the scapula, those are all quite easy to palpate, especially in someone who is thinner. If you're interested, you can go to the YouTube link below and they'll kind of walk you through a lot of these palpations. When looking on the posterior side, I mentioned earlier that the medial border can be a good landmark, and that's because when the arm is fully abducted, so fully away from the head, shown here as like being up on your head by this person demonstrating, you can actually use that medial border to determine where the sixth rib is, and where the sixth rib is will show you where the oblique fissure of the lung is. So it can be pretty important clinically. Now, of course, all of the bones in the shoulder can be fractured and they're quite easy to fracture. Humerus fractures are pretty common, but the one I want to talk about is actually the clavicular fractures, so fractures of the clavicle. And because this is quite common in young children, it's a fairly thin bone there, ossification hasn't fully set in, but really because of the location of the clavicle fractures. So typically clavicle fractures will occur in one of the third parts of the clavicle. So if you lay out a clavicle and break it into three parts, typically the clavicle will break along those third points because that's where the most pressure is put on the clavicle. Typically, part of it will actually be pulled upwards. So when it's broken in half, the medial fragment will actually be pulled up from its attachment to the sternocleidomastoid, and the lateral fragment is actually going to be pulled down from gravity. The muscle that you see kind of wrapping around, that will be your trapezius, but it does not have enough force to actually keep that bone in line. So you kind of get a very odd and potentially dangerous open fracture that has been moved. Okay, so next let's talk about what holds the shoulder together. And we're going to talk about ligaments. So ligaments are typically bone-to-bone attachments of thin, thick fascial sheets, while tendons are from muscle to bone. So we have both intrinsic and extrinsic ligaments of the shoulder. Intrinsic ligaments are basically those ligaments that are attaching the scapula, particularly the glenoid fossa, to the humerus, so that glenohumeral area. There are two that are pretty important. The most deep one that goes all the way around the glenohumeral joint is going to be your glenohumeral ligament because it's connecting your glenoid fossa to your humerus. And this basically kind of brings up the bulk of the strength on the anterior side. If you look, there's a little bit of a weakening where you can see that glenohumeral ligament kind of pooching downwards in this picture. And that means that inferior to the glenoid fossa is going to be the weak point of the shoulder. And that's where most shoulder dislocations happen. And we'll talk about that in a little bit. But just keep that in mind. And then the other intrinsic ligament is going to be the coracohumeral, and that is going to go from the coracoid process to the humerus, and it kind of lays just superficial to that glenohumeral ligament. And then you also have a fibrous capsule that is basically where a lot of tendons of the shoulder, so from muscles of the scapula going over to humerus, where they kind of combine. And we'll talk about that more in a little bit. Next, we have extrinsic ligaments. So these have nothing really to do with connecting the scapula to the humerus. These are more just kind of within that region. So the first one that we have is the transverse humeral ligament, and this goes over the intertubercular groove. So it connects to the greater tuberosity and the lesser tuberosity and actually creates a full canal. And this full canal is where an important tendon of the arm, the long head of the biceps tendon, actually sits as it goes up to its attachment point. Next, we have the acromioclavicular ligament. This is attaching the acromion to the clavicle. This is important for superior displacement of the clavicle. So basically, when we move, it keeps the clavicle because it's kind of floating between our appendicular and our axial skeleton. And so it kind of keeps it in line at the shoulder region. Then we have the coracoacromial ligament. So this is going to kind of create a roof over the glenohumeral ligament, going from the acromion to the coracoid process. And so because it creates this type of roof, it's going to prevent upward dislocation of the humerus. And then lastly, we have the coracoclavicular ligament. These are actually two ligaments, the conoid and the trapezoid. You don't need to know anything further from that. And these are the guys that helps try to prevent the inferior displacement of the clavicle. Next, we're going to move on to joints. So we have a scapulothoracic joint, sternoclavicular joint, acromioclavicular joint, and a glenohumeral joint. And we're going to talk a little bit more in detail about those. So first up is the scapulothoracic joint. This is not a true joint, so it's not between kind of a bone and a bone. This is actually between muscles. Muscles that attach to the scapula and muscles that attach to the thoracic cavity. Now, why we talk about it is because there is free movement between the scapula and the thoracic cavity, and it's very important for our range of motion, or our ROM, that's what ROM is, of our shoulder. If we don't have this joint, we are very limited in our shoulder motion. So the scapulothoracic joint can do several motions. Next, we have the sternoclavicular joint, or the SC joint. So this is between your clavicle and your manubrium of the sternum. This is a typical synovial type joint. It has a capsule, it has an articular disc inside of it, it has synovial fluid, which is kind of a jelly type look. It almost kind of looks like snot in a way, but that would be like your synovial fluid. And basically this joint allows for the clavicle to move next to the manubrium. So we don't really think about our clavicle moving, but if you put your fingers right at the edge of your clavicle and put your arm all the way up to the sky, you can actually feel that SC joint move. And this is also very important because this is the only joint that it allows for an attachment site between your upper limb and your axial skeleton. So if you did not have your clavicle, our arms would not be attached other than just by muscles, basically. So very important joint. Um, this joint, like I mentioned, it can move. Mostly it's circumduction, so rotating, allowing for the clavicle to rotate in response to the scapular movement. And that's about all I want you to know on that. Next, we have the AC joint or the acromioclavicular joint. So this is between the acromion and the clavicle. This is again another synovial joint that allows for rotation, particularly again that clavicle moving with the acromion when the scapula moves. Most of these motions are gliding motions. A little bit of rotation can happen, but mostly gliding. And then this joint is actually kept stable by the coracoclavicular ligament. The AC joint is quite commonly damaged by something called shoulder separation. So shoulder separation and shoulder dislocation occur at two different joints. Shoulder separation occurs at the AC joint, shoulder dislocation occurs at the glenohumeral joint. So the coracoclavicular ligament gives this joint strength. When damage happens, basically the severity or the type of AC joint separation that occurs is determined by how the coracoclavicular ligament is damaged. So if you look here, here's the x-ray where you can actually see the clavicle lifted up, separating it from the acromion, and then the different types with the different types of coracoclavicular ligament damage are on the right. Basically, if you tear both of the coracoclavicular and also tear that acromioclavicular ligament at the AC joint, you can cause superior movement of the clavicle or inferior movement, where inferior movement of the clavicle is the most severe and most damaging. Lastly, we have the glenohumeral joint, which is arguably the most important joint of the shoulder. So this is that typical ball and socket where you have the socket part or the cup with that glenoid fossa and the ball being the head of the humerus. The glenoid fossa, when you look at it on just the scapula, just the bone, it looks quite shallow, but it actually has a help of something called a labrum that kind of creates a deeper cup. So it takes it from being kind of a shallow dip to a very strong cupping action to where it's a perfect fit around the humerus. It is a very mobile joint and it takes a lot of pressure, but damage can occur just because it's only held together by ligaments and muscles, but they do give it as much strength as we need usually on a daily basis. Movement at the glenohumeral joint is all encompassing, so basically everything happens. You can have flexion by putting your arm forward, extension, putting your arm backwards, abduction, so moving your arm away from the body, adduction by adding to the body. You can have medial and lateral rotation. So if you fix your forearm, if you make your elbow a 90-degree and fix it and just kind of rotate towards medial and then move your forearm lateral without moving your shoulder, you actually have rotation of the humerus at the ball area. And then putting them all together will basically give you circumduction. So the ability to make circles with your arm. So all of these movements are very important for the glenohumeral joint. Talked earlier a little bit about the dislocation of the glenohumeral joint. So this is basically movement of the ball of the head of the humerus out of its socket that's made by the glenoid fossa. Talked also about that glenohumeral ligament being weak inferiorly, that little pooching, and there's no other ligaments there, no other muscles that attach there that can kind of help support it. So when you dislocate your shoulder, it's immediately going to go inferior. Now, the type of dislocation will depend on where it moves after that, whether it moves anteriorly or posteriorly. Almost all of them are going to move anteriorly. Posterior dislocations, so inferior movement then posterior movement, are very rare. A lot of times these dislocations happen just by getting hit in the shoulder or by twisting your arm very severely. One kind of clinical note that needs to be made with this is that if when the head of the humerus dislocates inferiorly and moves anteriorly, it can actually damage and compress a very important nerve called the axillary nerve. This axillary nerve is, you'll learn, is going to go to your deltoid, and so can really kind of affect movements of your arm. So keep that in mind. A shoulder dislocation of the glenohumeral joint can cause axillary nerve damage. Okay, so now we're going to talk about scapulohumeral rhythm. So scapulohumeral rhythm is basically just the movement of the scapula to the humerus. Basically what this means is that for every 2 degrees the humerus moves, that means that 1 degree of the scapula has to move. So if the humerus is moving 120 degrees, that means that the scapula also has to move 60 degrees, creating a full 180-degree change. How this happens is by different steps that allow for different parts of the shoulder to move. So the first 30 degrees is going to be primarily humerus. So if you start from a fully adducted position and then move your arm away from your body, so abducting it to that first 30 degrees, if someone puts their hand on the back of your scapula, which I'm not suggesting right now with COVID, you can actually feel that there's no scapula movement, just humeral movement. When you start getting into about the 30 to 90 degree range, the humerus and the scapula are going to move together, so we're starting that 2-to-1 ratio. But when you get above that range, when you kind of get above 90 degrees, that's about as far as the humerus can move by itself. And so the scapula is going to basically swing the rest of the way. So that's that movement at that scapulothoracic joint. Basically what this is doing is that when you kind of get to 90 degrees, if your scapula didn't rotate to allow for a full 180 degree rotation, it would basically hit your acromion and your coracoid process, which A, would be uncomfortable, B, not good for the long life of your arm, and also just not allow you to go any farther because bone on bone is strong. So scapulohumeral rhythm is important for full motion of our arm. And it kind of looks like this, where you can see starting out, not much scapula movement, then humerus and scapula move together, and then you can really see that scapula kind of upward rotation quite significantly. Now, because there is so much movement at the shoulder, we use these things called bursae to kind of prevent friction, and help reduce damage, basically. So bursae are just synovial filled membranes that sit in these high traffic areas. So the two that we're going to talk about for the shoulder are going to be the subacromial and the subdeltoid. So the subacromial is going to be on top of the ligaments of the glenohumeral joint, but just underneath the bone of the acromion, so below the acromion. And then the subdeltoid is going to exist kind of around that greater and lesser tuberosity area, just deep to the deltoid. And then, of course, you can always get bursitis from these from overuse, from basically constantly irritating it by a lot of movement. Now we're going to move into blood supply. Before we talk about the direct blood supply to the shoulder, we're going to talk about the blood supply basically to the entire arm because it's one continuous vessel. So you have the subclavian artery that's coming off that brachiocephalic artery, where the common carotid and the subclavian branch off of it. Once the subclavian goes underneath the clavicle, it doesn't branch, but its name changes to the axillary artery because it's in the axilla area or the armpit area. And then once the axillary artery gets past the border of a muscle called teres major, it'll then become the brachial artery. So this can be pretty useful in determining where you are, but it also makes it a little more complicated because there's multiple parts to each of these arteries that we'll need to talk about. So for the shoulder, subclavian artery and axillary arteries are what's going to supply the majority of the shoulder. I'm only showing you a posterior view here. There are one or two branches off the anterior view, but they're not quite as important as these ones that are going to the posterior scapula. So starting off with the subclavian artery, we have two. These are either going to come off the thyrocervical trunk or the third part of the scapula. And these are going to be your suprascapular artery going along the superior edge of the scapula and the dorsal scapular artery going down the medial border between the vertebrae. So this is the part that's closest to the midline. The suprascapular artery, I'll go ahead and make this point here and it'll come up a little bit later, but the suprascapular artery will go superior or on top of something called the superior transverse scapular ligament. And again, we'll talk about that a little bit more later. The axillary artery is the other part of this long vessel that gives to the shoulder. The main branch directly off the axillary artery is going to be your subscapular artery, and it'll give off two important branches. The first being thoracodorsal artery, which is going to go along the lateral border of the scapula, and then the scapular circumflex artery that will kind of create a C, creating a circle around the scapula, giving off branches, but also eventually meeting up with the suprascapular artery. So if you're above the spine of the scapula, you're probably looking at suprascapular. If you're below the spine of the scapula, you're looking at scapular circumflex. Now, these arteries can create this kind of border around the scapula because they will create things that are called anastomoses with each other. So giving blood supply to an area that would pretty much be ischemic or have no blood supply to it. So for example, the thoracodorsal artery and the dorsal scapular artery will anastomose or create a connection at the inferior angle of the scapula because otherwise that area would just receive no blood supply. So something that can keep in mind. What also kind of helps with these anastomoses and connections, so anastomoses between like thoracodorsal and dorsal scapular, but kind of these connections between suprascapular and scapular circumflex, is that it kind of depends on where an injury or a ligation occurs will kind of determine the damage and if the shoulder just completely becomes ischemic. So the first one that we're going to talk about is if we have an injury or it is tied off during surgery through like something called a ligation on the axillary artery. Keep in mind that this is the axillary artery above the subscapular artery. So we are superior to the subscapular artery. If an injury were to occur there or blockage of some sort were to occur there, because there are different routes, particularly the suprascapular artery and like something like the scapular circumflex artery, you can actually get around that blockage with something called retrograde blood flow, so kind of going backwards, to help supply the areas that have been blocked off. So blood can go into the suprascapular, continue along into the scapular circumflex artery, dump into the subscapular, and then continue on the rest of the arm. So in particular, not really much ischemia or loss of blood flow occurs. However, if this same injury ligation occurs inferior to the subscapular artery or below the subscapular artery, when this blood flow continues along the suprascapular artery, the scapular circumflex, and gets to subscapular, it can't go any farther because it's below where retrograde blood flow can occur. So you will actually lose blood supply to the rest of your arm because that axillary artery becomes brachial artery, which supplies your arm, forearm, hand. So below subscapular, inferior to subscapular, damage to the artery will prevent blood flow to the rest of the arm. Above or superior to subscapular will allow for retrograde blood flow and for blood flow to reach the rest of your arm, forearm, and hand. So keep that in mind. Okay, so now we're going to get onto the muscles, kind of the big point of the shoulder. We're going to separate this into different areas. So first we're going to talk about the muscles that basically attach your appendicular skeleton to your axioskeleton for the upper limb. And these are going to be pectoralis major, minor, subclavius, and serratus anterior. Starting off with a serratus anterior, this is a muscle that kind of gets its name from a serrated edge of a knife, so creating these little tooth marks that will go from the medial border of the scapula, so that's its distal attachment, to its proximal attachment of ribs 1 through 9. Sometimes it's 1 through 7, 1 through 8, but most of your ribs, you have 12 ribs, so most of them are going to have a serratus anterior, and you should be able to see the jumping of the attachments in lab. This guy is responsible for protracting the scapula, so it's usually referred to as the punching muscle. So if you punch forward, your scapula will move forward. Retraction is the opposite, where it goes towards midline, so this is going away from midline, and it's innervated by something called the long thoracic nerve. Now, something that's kind of unique about this long thoracic nerve is that it runs superficial to the muscle. So typically nerves will run underneath the muscle as kind of a protection element. But long thoracic nerve runs on top. So when you go into lab and dissect, you should be able to see it run right on top of all those serrated edges. Also, another important landmark to remember is that the long thoracic nerve runs with its lateral thoracic artery. So how I remember this is long has an N in it, so that means it's the nerve. Lateral has an A in it, that means that it's the artery. That's the only way I can keep it straight. So long thoracic nerve and lateral thoracic artery travel superficial to the serratus anterior, basically leaving it open to damage. And when this is damaged, this can create something called a winged scapula. So if serratus anterior allows for protraction, you remove protraction. Well, the opposite effect of that is retraction. So this winged scapula is basically an involuntary retraction of the scapula when it's fixed. So if you put your arms against the wall, it'll create this type of look. One way you can kind of remember this, if you can't think of winged scapula with this long thoracic nerve injury, is C5, C6, C7, which are its nerve roots. Spread your wings and fly to heaven. So fly, winged, if that helps. Moving on to the anterior side, we have the pectoralis major. So this has two heads. It has a clavicular head and a sternocostal head, where the clavicular head is mostly going to be flexing the humerus from kind of a neutral position, so bringing your arm forward, and the sternocostal head is going to help extend the arm, so bring it back to neutral from that flex position. So they kind of work in tandem with each other, and you can see them twist as they go over to their distal attachment at the lateral lip of the intertubercular groove. So it attaches in that groove area that separates the greater and lesser tuberosity, but basically about a third of the way down the shaft. And then it is innervated by the medial and lateral pectoral nerve. So two nerves innervate this very large muscle. If you remove the pectoralis major and look below it, so if you reflect it from its sternal attachments and its clavicular attachments and pull it backwards, you will actually see the smaller pectoralis minor underneath it. This is mostly just a stabilization muscle. It doesn't cross a joint in effect, so it doesn't have much movement. It attaches to ribs, so particularly ribs 3 through 5, and goes all the way up to that coracoid process. It is innervated by the medial pectoral nerve. One thing that I want to bring your attention is that the medial and lateral Lastly, we have the subclavius. This is a very minor muscle that basically attaches your clavicle to your first rib. Does nothing but really kind of anchor. It does help with a little bit of depression of the clavicle. Probably won't see a great one in lab, just because as we get older, most of our muscles kind of shrivel up and get smaller, and so most of our donors are older, usually around 80s and 90s, so we typically don't see one. And it's also innervated by the subclavian nerve. Next, we're going to look at the posterior axioappendicular muscles. So this is basically going to be your trapezius and your latissimus dorsi. The trapezius is a very large, almost diamond-shaped type of muscle with 3 different fibers, a superior, which kind of goes from superior to inferior, middle, which are transverse, and inferior, which also has a superior to inferior type movement, going to their midline attachments at the spinous processes, usually all the way up the cervical vertebrae, all the way to the external occipital protuberance, and then inferiorly all the way down your thoracic vertebra, all the way down to T12. These will continue that kind of diamond shaped by attaching to the spine of the scapula, wrapping around to the acromion, and then all the way in front to the clavicle. So it has a very broad attachment area. This broad attachment area, as well as the different fiber directions, allows for each of these 3 parts to have a different function. So your superior fibers of your trapezius are going to help elevate your scapula, so like shrugging your shoulders. Middle is going to help retract or pull towards midline, and then your inferiors are going to help depress your scapula or move your shoulders down. All 3 of these are innervated by a cranial nerve, actually, called the spinal accessory nerve. So that is, even though it's a quote-unquote back muscle, it does actually get its innervations from a cranial nerve. Spinal accessory nerve, cranial nerve 11. You can test this muscle quite easy by putting pressure on the shoulders and telling your patient to shrug them upwards. And so any sort of weakness that you feel could suggest that your trapezius is damaged by either a strain, muscle tear, or a spinal accessory nerve injury. Moving inferiorly to the trapezius, you will find the very large muscle called latissimus dorsi. This is a muscle that's also attaching to the spinous processes, except from the thoracic to lumbar to sacral levels. And then we'll actually move anteriorly to attach to the floor of the intertubercular surface. So this is a posterior muscle going anteriorly for attachment. Which is important because it actually gives this muscle a kind of wide range of movements. Probably it's one of its most important movement is going to be adduction, so it helps pull the humerus into the body. It will help extend the arm backwards, so extension, and it will also help with medial rotation of the glenohumeral joint. Because if you start from a posterior position and attach anteriorly, anytime those muscle fibers contract inwards, it will actually kind of pull and rotate the humerus to where it's going to be, its attachment point is going to be closer to the thoracic cavity than where it started, so allowing for that medial rotation. All of these different activities of the latissimus dorsi is why it's a really good swimmer's muscle. So some people kind of say that it looks like a fish. To me, it looks like a chicken, especially with the little attachments going to the intertubercular sulcus. So take what you want from that. It's innervated by the thoracodorsal nerve. One kind of way to help remember this attachment, the pectoralis major attachment, and one other muscle that we'll talk about in a little bit called teres major, as that it's the lady between 2 majors, because the pectoralis major attaches to the kind of edge of the intertubercular sulcus. This attaches to the groove. So major, major, lady, latissimus dorsi sitting in between, if that helps you any. And then you can test this muscle by basically telling a patient to hold their arms out at 90 degrees and telling them to adduct against resistance as you're kind of holding their arm and pushing against it. So the thoracodorsal nerve and artery run together just like the long thoracic nerve and the lateral thoracic artery do. These are in kind of a close area. Remember that the long thoracic nerve and lateral thoracic artery lie superficial to the serratus anterior, which is a little unique. while the thoracodorsal nerve and artery lay deep to the latissimus dorsi. So in lab, when you're looking at them, you really need to look at where they're going. So the lateral should, the thoracodorsal should be a little more lateral, while the long thoracic nerve should be more medial because that's where their muscles are. So something to keep in mind. So now we're going to remove the trapezius and latissimus dorsi to look at these deep axio-appendicular muscles called the levator scapulae, rhomboid minor, and major. So the levator scapulae is going to go from that superior angle all the way up to the transverse processes of C1 through C4. It's going to work with elevating the scapula, also a little bit with downward rotation, but mainly elevating the scapula, which is where the name levator scapulae came from. And it is innervated by the dorsal scapular nerve. On the right side of your screen, we have the rhomboid major and minor, while the major is going to be the more inferior of the two muscles, and the minor is going to be the superior, smaller of the two. Sometimes in lab, these do not have a clear distinction, and we can kind of find where it looks like there's a natural split and make that distinction. These are going from the medial border to the spinous processes, while the minor is going to C7 through T1, and the major is going inferior to that to the T2 through T5 spinous processes. And this is mostly to do with retraction and also downward rotation. And it's also innervated by the dorsal scapular nerve. So these three muscles along that medial border of the scapula on the posterior side are going to be innervated by the dorsal scapular nerve. Don't forget that the serratus anterior is on the anterior side attaching to the medial border, but it is not innervated by dorsal scapular nerve. That is innervated by the long thoracic nerve. Okay, lastly, let's talk about the scapulohumeral muscles. So the scapulohumeral muscles are basically originating or attaching at the scapula and going to the humerus. And there's a lot of them, so we'll go by them step by step. The first and largest muscle is going to be the deltoid. It kind of creates the cap of your shoulder, gives a nice kind of rounded appearance to the shoulder. It, just like the trapezius, is separated into three parts: an anterior, middle, and posterior fibers of the deltoid. And just like the trapezius, they all have different movements because their fiber direction differs from their attachment points. So it'll attach from the clavicle to the acromion all the way back to the spine of the scapula, very similar to the trapezius, and then we'll kind of converge into one tendon and attach at that deltoid tuberosity. These different attachment points give different actions. So the anterior is going to be more flexion and medial rotation. Middle fibers are going to be abduction. Posterior fibers are going to be extension and lateral rotation. So as you kind of walk your way around, the actions kind of slowly change. And then this is innervated by the axillary nerve. So when we talked about shoulder dislocation earlier, this axillary nerve that supplies all of the deltoid and the skin as a sensory nerve above the deltoid could be damaged. You can test the deltoid by starting at an abducted motion at 15 degrees and then tell the patient to continually abduct against resistance. Now that axillary nerve injury, what it kind of looks like is you will lose weakness in being able to abduct your shoulder, but also some weakness in flexion and extension. Abduction will probably be the most important past 15 degrees just because the deltoid is the main muscle for that, while there are others that help with extension and flexion of the shoulder. They will also have a loss of sensation over the deltoid because the axillary nerve has not only motor components that go towards the muscle, it also has a sensory component that does the skin. Typically, when a nerve is injured, and if it's injured for a long time, you can actually get something called atrophy. So if you look at the picture of the gentleman on the right, you've lost that nice cap type of look, and you can actually see the head of the humerus quite clearly. So long injury of the axillary nerve can lead to atrophy. So weakness, particularly in abduction, loss of sensation, and eventual atrophy that can be caused by shoulder dislocation, stab wounds, something that damages the axillary nerve. Next, we're going to talk about the teres major. This is kind of a round muscle on the inferior portion of the scapula, going from the medial border at the inferior angle, passing anteriorly to the medial lip of the intertubercular surface. So that lady between two majors that we talked about earlier, this is the second major. So pectoralis major is on the lateral lip of the intertubercular sulcus. The latissimus dorsi is on the floor, and then the teres major is on the medial lip of the intertubercular sulcus. So lady between two majors is a pretty easy mnemonic for that. This is going to mostly be used in adduction, so bringing the arm in, and also medial rotation. If you remember latissimus dorsi, where it started from a posterior point and then attached on an anterior point, the muscle movements basically mimic the latissimus dorsi because they're going to the same location from almost the same origination. And then this guy is innervated by the upper and lower subscapular nerves, which are branches off the brachial plexus. Now, with the deltoid and the teres major out of the way, we can now talk about the rotator cuff muscles. So the rotator cuff muscles are termed this way because they help with medial and lateral rotation of the humerus at the shoulder, except for one, which is going to be the supraspinatus. But the four rotator cuff muscles that we have are supraspinatus, infraspinatus, teres minor, and subscapularis. Teres major is not a part of the rotator cuff muscles because its attachment is completely different than the four rotator cuff muscles. We're going to start off with the only anterior originating muscle called the subscapularis. This is going to sit within that subscapular fossa, go laterally, and attach to the lesser tuberosity of the humerus. Because of this area, if you can imagine the fibers kind of closing together with contraction going from a medial to lateral point, it's going to cause medial rotation of the shoulders, so moving the shoulder inward. And it's innervated by the subscapular nerve. So pretty easy to remember that. Subscapular nerve innervates the subscapularis, which sits in the subscapular fossa. So pretty in line on that one. Next, we're going to talk about the oddball of the group, which is the supraspinatus. This is the only muscle of the rotator cuffs that does not have anything to do with medial or lateral rotation of the arm. Talked about earlier with the deltoid, testing it past 15 degrees of abduction as it continues on to 180 degrees of abduction. And that's because the supraspinatus from 0 to 15 degrees of abduction is the muscle that is most in control. It's going to sit within the supraspinatus fossa and is going to be innervated by the suprascapular nerves. So supraspinatus in the supraspinatus fossa, innervated by the suprascapular nerve. So all superior things. And then it's going to continue on to its distal attachment underneath the acromion, the clavicle, coracoid process, all the way over to the superior facet of the greater tuberosity. And because of its close location with the bones, whenever someone says that they have a rotator cuff injury, typically supraspinatus is the one that is damaged just because of its location around all of these high friction, high impact areas. And then, of course, test the supraspinatus from that 0 to 15 degrees of abduction against resistance. Deltoid would be 15 plus. Next, we have the infraspinatus, which is going to sit in the infraspinous fossa. It's going to go laterally, just like the supraspinatus did, and attach at the middle facet of the greater tubercle of the humerus, or the greater tuberosity of the humerus. So we're slowly moving from a superior to posterior type of attachment point. This is innervated also by the suprascapular nerve. So the infraspinatus and the supraspinatus are both innervated by suprascapular nerve. And it's going to deal with a lateral rotation of the humerus. When we talked about the subscapularis going from a medial to lateral attachment in the same anterior plane, creating medial rotation, If you then move that same medial to lateral movement in the posterior plane, when these fibers contract and go together, they're going to move the arm outward, causing lateral rotation. So thinking about it in a biomechanics sort of way could help if you struggle memorizing actions. We don't suggest that you memorize them. We suggest that you think about the muscle contractions and the biomechanics of it, but if you have to memorize, you have to memorize. So now let's talk about the kind of landmarks we want you to know with this suprascapular neurovascular unit, talking about the nerve, artery, and vein. So this all has to do with its orientation around something called that superior transverse scapular ligament, which covers the scapular notch. The scapular notch is basically just where it looks like where someone put their finger in like wet clay and made a little divot in the scapula as you go from superior border laterally to the supraglenoid tubercle. And what we want you to know is that the superior transverse ligament splits the artery and vein and the nerve. So the suprascapular nerve, which is a branch off the brachial plexus, is going to go inferior to the superior transverse scapular ligament. So it's going to go within that canal that is created at that scapular notch. On the other hand, the suprascapular artery and vein, where the artery and vein comes off the subclavian artery and vein, is going to go superior to that superior transverse scapular ligament. So what this means is that this ligament commonly ossifies, so it makes that little canal at the scapular notch smaller, which will compress the nerve, but it won't compress your artery and vein. So the blood supply shouldn't be compromised in any way because it's going on top or superior to that superior transverse scapular ligament. One way that you can remember this is Army over Navy. So Army, artery goes above, Navy is going to go below because they're in the water, if that helps. So suprascapular nerve goes inferior to the superior transverse scapular ligament, while the suprascapular nerve and artery go superior to that ligament. That'll be very important in lab and lecture. Okay, our last rotator cuff muscle is going to be teres minor, because remember, teres major is not a rotator cuff muscle. Teres minor is going to go from the lateral border of the scapula and attach to the inferior facet of the greater tubercle of the humerus. So superior tubercle of the greater tuberosity is going to be supraspinatus, middle facet is going to be infraspinatus, and inferior facet is going to be the teres minor. It's going to mimic the infraspinatus muscles actions because it's in the same area and attaching to the same spots, and it's going to be dealing with lateral rotation of the humerus. This is also innervated by the axillary nerve. Remember, we talked about the axillary nerve innervating the deltoid and also doing the skin over the shoulder. Now, if you have axillary nerve damage, are you going to be a little weak in lateral rotation? Probably. But you also have a lot of other muscles that kind of help take over that lateral rotation. So it won't be as significant as that abduction when you're at greater than 15 degrees. Something to keep in mind. One way you can remember these is something called sits. So if you hold a humerus and you put your index finger on the greater tuberosity and your thumb on the lesser tuberosity and kind of go around, you will have the attachment points for all four of the rotator cuff muscles. So superior facet, so it's where your index finger is going to sit at number 1. That's going to be supraspinatus, so the first S. 2 is going to be infraspinatus at that middle facet for the I. 3 is going to be teres minor for the T at the inferior facet. And then the only one attaching to the lesser tuberosity is going to be the subscapularis at 4, which will be your second S, giving you sits. You can also try to remember this by the 3 posterior muscles. Supraspinatus, inferior spinatus, and teres minor are all going to the greater tuberosity in basically superior to inferior motions. So supraspinatus is the most superior, so it's going to have the most superior attachment point. Teres minor is the most inferior, so it's going to have the most inferior attachment point. And then subscapularis is the only anterior muscle of the four rotator cuff muscles. So it's going to be the only one attaching to the lesser tuberosity. Either way, that helps, but these attachment points are fairly important for you to know. Last but not least, we're going to take all these muscles that we learned and we're going to learn the spaces of the shoulder. These spaces are important because they're where nerves and arteries exit, and also where damage can kind of occur a little more severely. When learning these spaces, I like to use the finger method on the right. It's something that you can always have with you as long as you know the muscles that make up these boundaries. So if you take your left hand and make it into a peace sign and kind of move it to where it would be like parallel to a desk, and you take your right hand, also put it in the peace sign, and actually put it in between your two fingers of your left hand, you will have the borders of these spaces. So on your left hand, your wrist is going to be like your medial border of your scapula, and on your right hand, as your hand continues down, that's going to be like your humerus continuing down of your arm. So talking about these borders, if you look at your left hand, your middle finger, or your most superior finger on top, is going to be the teres minor. Your index finger of your left hand is going to be the teres major. They make this type of V-shaped look. Then on your right hand, the ones that are going superior and inferiorly, because the muscles that are shown by your left hand are going medial and laterally, you would have the one, your index finger that should be right around like that first knuckle area. That will be your long head of your triceps because we're on the posterior arm. And then your middle finger of your right hand, right next to your fingernails, is going to be your humerus. So we have teres minor and teres major making the superior and inferior borders. And then you also have your long head of the triceps and your humerus making your medial and lateral borders, in a sense, for some of these. And using these four muscle groups, we have three spaces we need to know: the quadrangular space, the triangular space, and the triangular hiatus, also referred to as triceps hiatus by some. Pick which one you want, doesn't matter to me. So probably the most easiest one to see is going to be your quadrangular space. This is the one that's going to have all four of these muscles create a boundary. So quad, it kind of looks like a square, and it's going to have your superior border as the teres minor, the inferior border as the teres major, the medial border as the long head of the triceps, and your lateral border as the humerus, creating this square shape look. Once you find your quadrangular space, if you move medially, so on your fingers, that's going to be moving towards your wrist, you'll see where the V of your left hand creates a space. So this V is going to have a superior border of the teres minor and an inferior border of the teres major. And then a lateral border of the long head of the triceps. And this is going to be your triangular space. So triangular space is medial to the quadrangular space. Going back to the quadrangular space, if you move inferior, crossing the teres major, you will find that triangular hiatus. So the triangular hiatus borders are going to be: superior is going to be teres major, medial is going to be long head of the triceps, and then lateral is going to be the shaft of the humerus. So that all these four muscles give us the quadrangular space as the square. Medial to that is going to be the triangular space, and then inferior to the quadrangular space will be your triangular hiatus. Now the contents of these we're going to go through step by step. We're first going to start with our triangular space, and in this picture, if you hold up your fingers, that's going to be where the V of your left hand comes together. So teres major above it, teres minor below it, and the long head of the triceps lateral to it. This is giving you that triangular space. This is the only of the three space, the triangular space is the only space that is not paired. It only has an artery, and that is going to be your scapular circumflex artery, or the circumflex scapular arteries. Order does not matter, just get all three words in there. When you move laterally, towards the humerus, you get that square type of shape, and that's going to be your quadrangular space. When you find this, you will find the axillary nerve and the posterior humeral circumflex artery. We haven't talked about them yet. You'll talk about that more with the arm, but it's creating a circle, which is where circumflex is, going posterior behind the humerus. And these are going to be branches off the axillary artery. So axillary nerve, posterior humeral circumflex artery are in the quadrangular space. If you move inferiorly to the triangular hiatus, you will find the paired radial nerve, so innervation to the posterior arm, and you will also find the deep or profunda brachial artery. Profunda just means deep, so deep brachial artery or brachial profunda or profundus, all fine. So quadrangular space, triangular hiatus are all paired with a nerve and artery. Triangular space does not have a nerve. It is by itself with that scapular circumflex artery. That's all I have today. Here's anatomy of a cat for laughs and giggles. Again, please let me know if you have any questions, and we'll see you in lab.